Good morning and welcome to everyone. And before we begin today's proceedings, I would like to turn to our First Nations Health Council Chair, Charlene Belleau, who is a member of Asketum First Nation, to say those words that go before all others. So if I could go to you, Charlene.
Great-grandfather, creator of all good things, we pray to you and we thank you for this beautiful day. Great-grandfather, we pray to you and we thank you for all of our frontline workers. Great-grandfather, we pray to you for all of our community members that are suffering today from addictions, from opioid overdose. Great-grandfather, we pray to you to take all of your children in the palm of your hands, protect them and keep them safe. Great-grandfather, we pray to you for our leaders to continue to be strong, to be able to provide the support and the health services that our people need during these difficult times. Great-grandfather, I pray to you and I thank you for the First Nations Health Authority, the Health Council, and all of our partners for continuing to work together to support one another during these challenging times. Again, great-grandfather, we pray to you and we thank you for today, all my relations. Good, thank you, Kukshem, for being here today. My name is Charlene Belleau. I'm chair of the First Nations Health Council, one of 15 representatives from throughout the province in the 5 health regions. Our mandate is to advocate on behalf of BC First Nations in the areas of health, including opioids. As you'll hear today, the opioid crisis continues to disproportionately impact vulnerable BC First Nations people. The concurrent COVID-19 pandemic is creating challenges for those struggling with addiction. We need to work together as communities and nations to heal, to save lives, and to help many people who are self-medicating and at risk of dying from fentanyl poisoning and opioid crisis. Our people face significant health, social, economic, cultural, and political inequities linked to the social determinants of health, the root causes of poor health outcomes. It can be challenging to access timely, culturally safe treatment services for those experiencing addiction. Now, more than ever, our people need this support. Our youth, more than ever, need access to assessments and treatment. The First Nations Health Council has heard from many chiefs and leaders that community-driven, nation-based solutions that address the root causes of addictions and mental health and wellness are a top priority. As a part of this healing journey, properly resourced treatment centers and culturally safe harm reduction strategies will be critical moving forward. Making progress in these areas will require working in partnership. Both the Government of BC and First Nations Health Authority have each contributed $20 million to build 2 new treatment centers and renovate others. These centers provide much needed mental health services and substance abuse services for First Nations people in BC right now. This is a significant investment by the First Nations Health Authority and the provincial government, and an important part of improving the accessibility of substance use services for BC First Nations. We look forward to Canada's confirmation of its respective contribution to these efforts. Throughout our work, we've noted that self-determination is critical determinant of the overall health of our people. When our people have their authority and autonomy recognized and are supported with adequate services, our health improves, the knowledge exists within our communities. The First Nations Health Council is eager to work with the communities, nations, and our health governance partners to continue this important work. In doing so, we make our people and communities healthier and more resilient. Thank you.
Thank you for your comments, Charlene, and want to acknowledge, of course, that you have years of experience, both as chief of your community, as treaty negotiator and manager, but also in the work on Indian residential schools in response to this important element. So, so you have much experience, and I want to thank you for joining us here today and for your opening words and context. Next, I want to turn to Dr. Shannon Mcdonald to give you some of the specific information and data that really will help shape the overall set of interests relating to opioid overdose. And want to also say that Shannon similarly has many years of experience in First Nations health in several locations across the country, but also very importantly here in BC. She's a Métis Anishinaabe person with deep roots in the Red River Valley of Manitoba. So I'm very pleased to welcome her this morning to present the data.
There we go. Microphone. Before I get into the data, I want to acknowledge my colleagues at First Nations Health Authority on the ground and at the strategic level, our partnership with the Provincial Health Office, the Ministry of Health, and the Ministry of Mental Health and Addictions, our partnership with nations and their leaders going forward, and importantly, our partnership with individuals who have been affected. When I talk about these numbers, I'm talking about people. And there has been much pain and loss in our communities due to the loss of these individuals. And I want to acknowledge that pain and that loss. Do I not control the slides? Thank you. Next one, please. Thank you. So tragically, we have seen between January and May of this year, compared to 2019, an increase of 93% in the number of First Nations people who have been lost to opioid poisonings. A significant portion of that has been to fentanyl. 93%. And they have continued to spike. We've seen the numbers spike dramatically between March and May. Next, please. So why is this happening? For whatever reason during COVID, the availability of illicit drugs has changed. And there has been an increased toxicity of illicit drugs that are available to our community members. It's almost impossible for people to understand when they buy on the street exactly what it is they've gotten. They may be able to test for fentanyl using test strips or other methods, but the amount of fentanyl or other drug combinations is not as easily determined. COVID-19 has also forced people into isolation. We have asked people to remain at a distance from others, and especially in circumstances where very close contact might be necessary, having somebody with you while you are injecting is pretty close contact. People are choosing not to use overdose prevention sites. Many of them have been closed. There are fewer sources available for supervised consumption. And without having somebody with you with naloxone or the ability to phone for help, people are dying before they're reached. So the COVID-19 precautions have made it harder to support vulnerable people. And we're hoping that we can change that in the next few months.
Next, please. Right from the beginning, 4 years ago, we have seen that First Nations people have been disproportionately represented in the overdose deaths recorded in BC. At this point, 16% of all overdose deaths in BC between January and May of 2020 are First Nations people. This number was 9.9% in 2019, which we are and were, of course, very concerned about. The problem is getting worse, not better. And remembering that First Nations people represent only 3.3% of the province's population, it is particularly concerning that we are seeing these numbers. Next slide, please. So looking at these numbers, these percent, understanding that 3.3% of BC's population are First Nations people. First Nations people have been experiencing overdose deaths 3.8 times more than other residents in 2019. And in 2020, First Nations have experienced overdose deaths 5.6 times more than other BC residents between January and May of 2020. So that gap between First Nations people and other BC residents is widening in 2020. Next, please. So why? We know that there is insufficient access to culturally safe mental health and addictions treatment. During COVID, many treatment centers and treatment facilities stopped functioning. People could not access treatment even if they wanted to. And when people have attempted to access healthcare, there have been many stories of systemic racism as a barrier to that access. And we know that our generation have experienced intergenerational trauma. Grand Chief Doug Kelly once said, "We don't have a drug problem, we have a pain problem." And as Charlene mentioned earlier, we have many, many people that are self-medicating that pain using illicit substances because they have limited access to culturally safe mental health and addictions treatment. Next, please. So what has FNHA done? Right at the beginning of this 4 years ago, FNHA set up 4 pillars of care to work with and for the individuals who are being affected in the overdose crisis. FNHA has partnered with organizations in 8 cities to increase capacity in peer-driven outreach in the community and in primary care, understanding that those who have experienced substance abuse and substance use disorders are the most likely to be able to understand what people are going through and support the system in caring for them. We have participated in the distribution of naloxone kits delivered through First Nations sites and Aboriginal Friendship Centers. We have had identified 16 harm reduction champions who received training and Kickstarter grants to deliver naloxone, harm reduction, and substance use training in the communities. We facilitated dialogues in partnership with BC CDC's Compassion, Inclusion, and Engagement team to develop innovative and sustainable improvements in harm reduction services. We have Indigenous peers working at the Crosstown Clinic in Vancouver's downtown east side, supporting over 200 people who use substances at that location. An opioid agonist treatment has been more widely distributed in community health centers, and 7 more do so in this year and next. Next, please. We are working very hard with our partners on providing culturally appropriate mental health and addiction services, including, very importantly, land-based healing. Those services are being provided at 98 new sites. The land-based healing is a separate envelope of funding, providing subsidies to 226 people for accessing opioid agonist therapy at private clinics when that's the best availability for them. And with our partners in the provincial and federal governments, we're investing, as was mentioned, up to $60 million to build new and renovate existing First Nation centers in BC. We are establishing Indigenous wellness educator positions to facilitate community conversations about harm reduction closer to home. And a new program, FNHA's Unlocking the Gates peer mentoring program, has supported 173 individuals after their release from correctional facilities to make sure that they can access health services immediately upon release. Next, please. This is our last slide on this, but I thought it was really, really important. Each of these figures represents 10 deaths that have occurred within First Nations communities. These are not figures on a page. These are not numbers on a chart. These are people. And each of these people is loved and missed. And we don't want to add anything to the people we're seeing on these. Thank you for your time. Thank you for your support.
Thank you, and I think this gives, thank you, Dr. McDonald. This gives a good overall context and also shows some of the work that's underway with our partners and sets the table for some of our further discussion. Thank you for that. Next, we'll hear from Dr. Bonnie Henry, the Provincial Health Officer, who will give us a more high-level overview of the current epidemics and put some of this data in an overall context. By way of background, Dr. Henry has been the Provincial Health Officer since February 2018. Seems like a long time ago. So really excellent service in that time. And of course, she has an extensive experience in senior public health positions, both in Canada and abroad. So with that very brief welcome, I want to welcome Dr. Henry and ask her to make her remarks.
Thank you, and thank you very much for having me here this morning to be part of this discussion, very important discussion. I will start by saying I am speaking to you from the traditional territories of the Lapointe-speaking peoples here in Victoria, the Songhees and Esquimalt First Nations, and I am grateful to be able to work and live on these lands. The increase in overdose among First Nations people in BC is deeply concerning. It is part of a larger increase that we have been seeing, including with the 2 crises that we have here in British Columbia. And as you know, over 170 people, individuals, died from poisoning from the toxic street drug supply that we have here in BC. And as we have seen, First Nations people are continually differentially impacted by these deaths. And we need to know how we can do better to support Indigenous people, and particularly our First Nations people here in BC. We know this, as Dr. McDonald has said, the pain issue. And we know that there are many things that we do to help overcome that pain. And it is a serious health challenge for us here in BC, and one that is complex, and there are many different facets to it. We are very grateful for the partnership that we have with the First Nations Health Authority, that we're able to provide this information to actually understand the impacts on First Nations communities and make a difference by knowing what we can do to move forward. We've all seen, though, that the COVID-19 pandemic has thrown yet another challenge to us all. And again, it has more differentially impacted First Nations people in BC. And part of that, as we've mentioned, is about decreasing access to services because we have concerns about spread of virus. And that has led people to be more isolated, to be alone, to use alone. But of course, underlying much of that is the shame that many people feel around their drug use and feeling that it is not safe to talk to people about their drug use. And in particular, we know that there are issues with systemic racism that are preventing First Nations people from getting the services that they need in our health system and other parts of our communities. We know that people living with addiction can feel shame, and in many places are reluctant to come forward. And part of that is the criminalization of people who use drugs in BC. And again, that is another area where we know First Nations peoples are differentially impacted. We know, for example, that First Nations women are much more likely than non-First Nations women to die from a toxic drug overdose. And we know that Indigenous women are much more likely to be in our provincial correctional facilities, and majority of those are for drug-related crimes. So we need to do better at supporting Indigenous women and Indigenous people in being able to break that cycle and get out of that criminal justice system and get the support that they need in a culturally safe way. And that is something that we are working on together with the First Nations Health Authority. We know that we can make a difference by having safe and culturally appropriate services provided for people. And our partnership will continue to work on that. It is a challenge right now more than ever. We know that the toxicity of the street supply has gone up exponentially in this pandemic. And access to pharmaceutical alternatives to that supply is something that is in critical need across the province. And we are working on a number of different aspects to support that, and to support that in a way that provides safe pharmaceutical alternatives to people who need them. Part of that, working on getting an exemption under Section 56 of the Controlled Drugs and Substances Act that will allow nurses and their health professionals to prescribe these needed medications to people of the province, making access easier for people. So we do have these challenges that have just been compounded in the last few months, but we are committed to doing what we can to support the First Nations Health Authority and First Nations communities across the province to address both of the critical issues in our province now and in the future.
Thank you very much for your context and situating our overall discussion today within this certainly big picture and within the overall context of also our multiple crises that we're experiencing. So thank you for those comments. Next, I'll turn to BC Chief Coroner Lisa Lapointe, who will help us understand also more about who is affected by this crisis. And Lisa's been in her role since 2011, and she oversees independent investigations of about 10,000 deaths a year in BC. She's a graduate of Columbia Law School and has previously held the position of coroner, deputy regional coroner, and regional coroner on Vancouver Island. So with that, want to welcome Lisa, and we'll ask her to make her presentation.
Thank you, Richard. And I would like to acknowledge with gratitude that I am joining the meeting from the traditional territories of the Lekwungen-speaking people, the Esquimalt and Songhees First Nations. We have been collecting data on illicit drug fatalities for many, many years, and beginning in 2015, started to see a steep increase in the number of people dying. And those numbers just continued to grow and grow and grow. Since January 1st, 2015, we've had over 6,094 deaths in this province due to illicit substances. Those are primarily driven by fentanyl, which came to this province in about 2015. We didn't see illicit fentanyl prior to that. These are not prescribed opioid deaths. And over time, we've certainly seen more extreme concentrations of fentanyl in the deaths that we investigate, and particularly over the last few months. In 2019, we saw a drop in the number of those who died. In 2018, there were over 1,500 deaths. In 2019, a little under 1,000. And in some ways, that was celebrated as good news, and that's not right, because we can't normalize the number of people who are dying. And as we saw from Dr. Mcdonald's presentation, First Nations individuals and families are disproportionately impacted by these fatalities, and they are happening across the province in every community and in every walk of life. We know that using alone is a significant risk, as Dr. Mcdonald mentioned, and our coroners are more and more gathering as much data as they can about the circumstances in which people die, so we can help support evidence-based solutions. We know that although fentanyl is driving this, 50% of those who die also have cocaine in their systems. 34% also have methamphetamine in their system, and 30% also have alcohol. So this is a mixed drug use issue. It's driven by fentanyl, but certainly involves many drugs that people use, and really nobody is safe. We know that there are people who seek fentanyl, and they may use fentanyl safely for months, and then the one time they use, and because there is no formula for this, and the lab, I use the term loosely, these are often made in kitchens and basements and no quality control, and then somebody will die suddenly because there's just a little too much fentanyl and it tips them over the edge. Or people are not seeking fentanyl, they're seeking another drug and it happens to be fentanyl contaminated. So all of those who use substances are at risk now in this province, and it's quite frankly terrifying. We have, in our partnership with the First Nations Health Authority, in 2016 adopted the province's Indigenous Administrative Data Standard, and that is what has allowed us to identify the numbers of First Nations people dying. And we ask for every death in the province, whether the individual identified as Indigenous, Inuit, or Métis, because we know how important this data is to the First Nations Health Authority, and we know how hard the First Nations Health Authority has been working to address this crisis. My condolences to all of those who have lost a loved one. My coroners work with the families. We see the families and we see the impact, and all ages, from fortunately not too many youth, but from youth right up to people in their 70s and 80s. And as I think it was Dr. Mcdonald quoted Grand Chief Doug Kelly, this is what we see are symptoms of pain. And there's far too much judgment around this issue. As a coroner service, we continue to encourage all levels of government to adopt a comprehensive, evidence-based, non-stigmatizing approach to this epidemic. Judgment doesn't help. And certainly the illicit, illegal factor is very, very challenging when we're asking people to seek support and to feel free to go to healthcare facilities when there's a fear of being arrested or losing a child or losing a job. That is a very difficult thing to do. And so we encourage governments to continue to adopt an evidence-based, non-judgmental, non-stigmatizing approach. Thanks very much.
Thank you very much for your additional context and for your additional commentary on the system. I think those are really important additional elements to our overall conversation today. And I would like to now turn to our Acting Deputy Chief Medical Officer, Dr. Nell Wieman, who is the first female psychiatrist in Canada. And she's from Little Grand Rapids, an Anishinaabe woman from Little Grand Rapids, Manitoba. And she's a key resource in FNHA and in our approach to mental health and wellness. So with that, I'd like to introduce Nell to add commentary to today's discussion.
Thanks, Richard. Ani Boujou. I'd like to start by thanking Charlene Belleau for her opening words and prayers. I'm speaking to you this morning from Coast Salish territory, the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. There are a number of speakers assembled here today, and if there's some repetition in what we are saying, it is because of the seriousness of and sadness associated with the release of this First Nations data, and it cannot be overstated. Let us all remember, as it's been said by Dr. Mcdonald as well, that behind these grim numbers are First Nations people, our brothers, sisters, mothers, fathers, grandmothers, grandfathers, aunties, uncles, and cousins, people who loved and were loved. We mourn the loss of them. Behind these First Nations individuals who died from overdose between January and May this year are also stories, their life stories. Many of their stories include the wide-reaching impacts of colonization, the disempowerment and enduring trauma of experiences such as the Indian residential schools, the 60s scoop, Indian hospitals, and the harms associated with ongoing anti-Indigenous racism. We know that substance use disorder can be a symptom of a person's distress. It correlates with the amount of emotional, mental, physical, and spiritual pain that they are in. For First Nations people, distress is often rooted in grief, loss, disconnection, and unresolved intergenerational trauma. And so in thinking about the stories of First Nations people who struggle with substance use and who may be reflected in today's numbers, we need to go deeper. The dual public health emergencies of the COVID-19 pandemic and British Columbia's opioid crisis have intersected in a way that has had unintended consequences and tragic outcomes for some of those who use substances. The impact of these crises on First Nations people, as has been stated, is proportionally greater than for the rest of the provincial population. And as has been mentioned by others, the public health measures necessary to flatten the curve of COVID-19 cases seem to have precipitated unforeseen negative changes in the increased toxicity of the drug supply, in the ways in which people are using, and their decreased access to harm reduction and treatment services. These factors, in combination with pre-existing inequities in the social determinants of health and the historical, intergenerational, and contemporary trauma that First Nations people endure, account for the devastating numbers of overdose deaths we see today. Additionally, the effects of the COVID-19 pandemic on our mental health and wellness are significant. Add these stresses to the already existing pre-pandemic mental health challenges that people who use substances face, and it becomes clear that we need to consider mental health services alongside substance use interventions and harm reduction strategies to address this marked increase in overdose deaths. The figures released today indicate that pre-COVID, the measures we were taking to address the opioid crisis among First Nations people were having a positive effect. This can offer us some hope while reminding us that we still have a lot of work to do. Too many people are still dying. We cannot stand still and watch the progress made in saving lives be lost. We have to adapt, and we have to be willing to try new things and try them quickly, or we will lose more lives and waste the progress that we had made. We need to do whatever it takes to reduce the number of First Nations deaths due to overdose, providing those who use substances with a safe supply, decreasing the barriers to accessing harm reduction services, substance use treatment, and mental health and wellness programs, reducing stigma around substance use disorders, and ensuring that all of these services are culturally safe, free from racism and discrimination. Our communities are demanding that we do more to address the crisis that has taken so many of their loved ones too soon. And since the beginning, the First Nations Health Authority has been looking at new and more effective ways of addressing the opioid overdose crisis in response to this demand. These have been outlined by Dr. Shannon Mcdonald earlier today. I would like to end by thanking our partners for their support, both in their response to these dual public health emergencies and in their efforts to increase cultural safety across the provincial healthcare system. Let us redouble our efforts addressing the opioid crisis in First Nations with compassion, action, and innovation. Thank you, Che Miigwech.
Thank you very much for your closing comments, Dr. Wieman, and also just in doing so want to reflect that the partnership elements are really critical, and we have some of our key partners on the line and available today. So I think this is a good beginning conversation, and essentially is sounding the alarm on an emerging and changing context. So with that, want to turn this back to Jordan Humphreys, who will moderate the media Q&A portion. So over to you, Jordan.
Great, thank you, Richard. So I'm going to help moderate the Q&A portion of our program. We have approximately 30 minutes allocated for Q&A. We'll try to take as many questions as we can during that time. To ask a question, please raise your virtual hand by clicking the hand icon on your Zoom toolbar. When it's time to ask your question, I'll introduce you. I need to remind you to please unmute your microphone in order to speak. And also please specify who your question is directed to. We're going to take our first question from Camille Baines.
Hello, thank you for taking my question. I'd like to know what specific types of non-judgmental approaches could be adopted by all levels of government. The coroner mentioned this, and this has been brought up before. Decriminalization of small amounts of drugs for people using them for their own personal use is one thing that's come up before, but I'd like to know what other types of approaches could be adopted. Thank you.
It's Dr. Mcdonald. Sorry, I don't know if you're directing that at me specifically or anybody else on the panel. We've had many conversations going forward. When we started this 4 years ago, the concept of widely available opioid agonist therapies and naloxone were new ideas. And FNHA and our partners have all worked very hard to try to make those available in circumstances where people don't have to be experiencing humiliation or stigma, as much as possible, normalizing it as medication available for somebody's health need. As we move forward and start talking about things like safe supply, the original discussions that came up around the tables about, can we do this? Is it possible? Is it safe? Is it, unlike some people have suggested, are we supporting people in their addictions? Well, in some ways we're supporting people while they have the need for this medication to get through day to day, and allowing them to normalize their lives and receive treatment in a very positive way. It's a new way of working. We are all learning as we go ahead, and hopefully we can move forward on making other things we haven't really thought about yet available. The other thing, and I really appreciate Dr. Wieman's comments about accessing culturally safe services, because many of our community members have very specifically said they don't feel safe going to hospital or even calling for an ambulance in the fear that they will be treated badly and not receive any kind of support beyond the immediate need for treating an overdose. So I think we really need to work at all levels to make sure that the universality of substance use disorders is recognized, that some of the racist thoughts behind connecting substance use disorder with Indigenous people everywhere, understanding that that is a racist thought, but acknowledging that there are members of our community who need help and they need to be able to access appropriate health care for the disorder with which they're suffering.
Dr. Henry, I would ask for your comments.
Yes, and I think Shannon summed it up nicely. You know, one of the things that we have been advocating for, as you know, is around decriminalization of people who use drugs. And there has been quite a move nationally around people who get caught in these bail conditions and release conditions and are not able to meet conditions of not using a drug that they're dependent upon. So it is one of the complexities of dealing with this crises is that having access to a supply that is not going to kill you, that we know has a regulated amount of the drug and a pharmaceutical alternative to what we know is increasingly toxic on the streets, those go hand in hand. Being able to be safe to access those and in using those medications as a way to get some stability and overcome some of the chaos. And we know that when we connect with people, that is when we can move forward in helping them find their road to recovery, whenever that may be. So those are important things. I think we need to really look at it as any way that we can get safer to people who need them now is going to be incredibly important.
Lisa?
Thanks, Richard. Recently, I was listening to the radio and there was a union negotiator talking about a contract that they were negotiating. And one of the items that was in dispute was that under the current contract, if somebody tested positive for a substance, a random test, they could be fired. And they were having to negotiate that off the contract. And those are the types of things that push people underground. The stigma, the continued stigma around using substances rather than a comprehensive provincial and federal approach to this as a medical issue that we need to treat with medical solutions. We continue to people can be arrested, as I pointed out. People can lose their children. People in some occupations can lose their jobs. And that's what I'm talking about, that comprehensive approach that needs to be adopted at all levels of government. And you know, those types of clauses in contracts, or if you're looking at human rights legislation, substance use needs to be recognized as a medical issue that needs to be institutionalized, and the punishment that people face for this medical issue needs to be eliminated.
Thank you. Nell?
Thanks, Richard. I think I'll only add to the discussion by reinforcing the idea that, you know, when we're talking about non-judgmental approaches, we're really talking about dismantling the stigma around substance use as a medical condition, and for First Nations people specifically, the racism and discrimination that they face in accessing the healthcare system. For First Nations Health Authority, we have a partnership with the British Columbia Centre on Substance Use, and we have an initiative together where we share a First Nations Addictions Care Partnership Manager. And one of her tasks since the COVID pandemic has emerged in light of the increased overdose deaths is, we are pivoting our response because we've had to work somewhat more virtually to tackle this issue of stigma. And so a number of events are taking place across the province. One actually took place prior to COVID, but will continue to take place. The next event is taking place in the Surrey area, all about having these difficult conversations that we need to have around stigma. So, I really want to ask the question, I guess, back is, people really stood up and got behind the public health measures for COVID-19. And because that's an infectious disease, but when it comes to the ongoing opioid crisis, that has all kinds of other, stigmas associated with it. And so we need to really think hard about that. And then we also need to act at the same time so that we can prevent this dangerous trend we're seeing of increased overdose deaths.
Thank you. Charlene, do you have a comment?
Thank you, Richard. I just wanted to just add, coming from my background, we're dealing with at least 150 years of residential schools, 60 scoop day school students that have been violated and abused for years. So the root causes of a lot of what is happening is now playing out with the overdose crisis. And I just want to add that in the data and information, a lot of the opioid crisis is happening in the urban centers, where it's been easier for our people to just leave home and hopefully disappear in downtown Vancouver, where no one sees them, but really that disconnects them from our communities that care so much for them and want to be able to support them through the trauma that they need to deal with so that they don't have to be drugging and overdosing. So to me, our leaders have called, for ongoing support right at the community level so that we can bring our people home and be able to provide the kind of support that they need in facing this crisis. So I look forward to that and in continuing to improve that service right within our nations. Thank you.
So if there's not a specific person that the question is directed to, we'll go through the whole panel. So.
Great. We're going to move on to our next question from Chantel Bell-Richard with CBC. Just a reminder to please unmute your mic when prompted.
Hi, thanks for this press conference today. This question, I guess, would probably be directed towards Dr. Mcdonald and Lisa Lapointe. For Dr. Mcdonald, I was hoping you could specify who exactly is captured in the data that you presented today. So for example, is this limited to status First Nations people who are either from a BC First Nation and registered, have a registered address in BC? Just looking for clarification on the data capture. And then for Lisa, you had mentioned at one point that there was also an effort to capture other folks, so people, First Nations, Métis, and Inuit folks, and wondering if that data is also compiled as a comparison here, or is that something that we could expect to see in the future around data collection on all Indigenous peoples?
Thanks, Chantel. The data that we're using today is the data linkage with the First Nations client file, which identifies status First Nations individuals resident in BC who are registered to receive health services in BC. That's how we create the client file. And then there is a linkage back to the opioid mortality data that the province collects. So our data and what I'm reporting is very specifically status First Nations, but the work that we've done with the coroner service also helps in aiding the identification of non-status Métis and Inuit people, but I'll let Lisa respond to that.
Thanks, Shannon. So what we, starting in the latter part of 2016, the coroners now ask for every death reported, whether the individual identified as Indigenous. And if the answer is yes, then if known, First Nations, Inuit, or Métis. And we collect that data and we share all of the Indigenous data with the First Nations Health Authority. And then they determine based, as Shannon said, relative to the province's health client files, which data is most appropriate for them to use. And coroner's data is for every person who dies in BC. So they may or may not be a resident, but if they die in BC, then their death is investigated by a coroner.
Okay, so is it fair to say in the data overall that you've presented today that really with Indigenous people overall that overrepresentation would likely be even higher than the numbers we've seen today?
That's very likely, and in the past we have done a bit of a comparison between what the coroner service is able to collect and what we get from the client file. And the client file assists us in identifying individuals who the coroner may not have identified as a status First Nations person, because of course the person cannot self-report under the circumstances, and people who are with them and talking to the coroner may not have the information there. But there is a possibility in the future to do broader analysis of the coroner's files, and I wouldn't want to speak on behalf of Métis people in the province, but I'm sure Métis Nation BC, we've often had interactions with them and would support them doing that as well. It's much more challenging with regard to non-status and Inuit. Non-status, of course, because there isn't the same kind of collective that has the authority to gather the information, so that is challenging. And our representation for Inuit people in the province has been very limited. There are less than, in the last census, there were less than 1,000 Inuit people registered in the province, but I don't know that they've identified a representative organization.
Can I just add to that, in that we do have a partnership, my office, with Métis Nation BC. So we are getting more information around Métis in British Columbia and how they're being impacted by both the crises as well.
Great, thank you. We'll move on to the next question. This question we've received in written format. It's from Georgie Smith from the CBC, and I believe it's directed to Dr. Mcdonald. The question reads, in regards to the slide on stats for percentage of death relative to the wider population, January to May 2020 being 16%, is the 2019 stat of 9.9% for the same months or the whole year?
For the purposes of this report, we used the January to May of 2019 so that we could have a more direct comparison.
Thank you. Next question is from Briar Stewart with CBC. Reminder to unmute your mic, Briar.
Is there any further clarification you can give for where these deaths are occurring? Is it really spread throughout the province, or are they more concentrated in certain areas like Metro Vancouver? And then my second question, this might be for Dr. Henry or for anybody else who feels like they're able to answer it. I'm wondering about numbers in terms of people who are accessing safe supply ever since that federal exemption was granted. I know there are some numbers about the number of people who have been able to access it, and I'm wondering if there is data related to the number of Indigenous people that have been able to access it.
I know, Shannon, if you want to talk about there is an urban focus on people who are, for the data that was presented today, but not necessarily the same urban areas as for First Nations people in BC. And I know that there's an infographic that's being distributed along with the news release that has some of the urban areas that are more differentially affected in the First Nation data. In terms of people accessing the safer supply, I don't have that broken down by indigeneity. I know I can look and see, but I don't believe that we've linked that information, and so it would depend on whether somebody self-reports. But for the most part, that's probably not being collected at this point. But it's a very good question.
Thanks, Bonnie. Yes, this I think is what Bonnie is referring to. Does identify communities where we've had a significant number of overdoses occur. They are primarily urban. We have had cases in non-urban communities, absolutely. But because of privacy concerns and small numbers in those communities, we haven't been reporting because of the risk of re-identification of individuals. But I think the other thing is something that Charlene brought up earlier, is that individuals, for reasons of the need to access medication or services, and there is a sense of, when we talk to our peers that work with us, there is a sense of community among substance users, people who use substances, excuse me, where there's a collective of support for each other. And so people are drawn to those communities where they are feeling less judged, where the stigma may not be as strong, and therefore not only are they better able to access the medications they need, however, on the illicit market, but they find other reasons to find supports in the urban center and less stigma.
The only other thing that I would add would be that in terms of some of the the initiatives that we're using to address the opioid crisis, such as safe supply, is that there are inequities in access to these initiatives across the province. So paired up with what Dr. Mcdonald just shared around people maybe finding community in urban centers where there is less stigma, or there's more support and there's more peer support, there's definitely differential access to these different services across the province, especially if you live in rural and remote areas.
Okay, thank you. We're going to turn our next question to Cindy Harnett, Times columnist. Please remind yourself to unmute your mic when prompted.
Hi, thanks for taking my question. I guess this goes to the most appropriate person if someone would volunteer. We could be living with the pandemic for a year or more. Are you expecting to see this continued spike in First Nations deaths continue to rise? And the interventions we've made with respect to preventing transmission of COVID-19 have been so successful in BC. Why is the same interventions not working in terms of opioid deaths? What is the main intervention that is missing or not successful?
Maybe I'll start and then I'll turn it to Shannon as well. So it's Bonnie here. It's challenging, but as we are looking for First Nations, but also for other people who use drugs in BC, how do we manage these two these two public health emergencies. And yes, as we are moving ahead in the next few months to a year, we are looking at how we can better have the supports for people. And I must say that it was the measure that we took to try and prevent transmission of COVID, in particularly in underhoused and homeless populations, people being in shelters, that had that unintended negative consequence of forcing people away from where they had support. So our overdose prevention sites have had to modify how they work, and some of them have become more mobile. For example, shelters had to have fewer people in them so that we reduce the risk of transmission. All of those led to conditions that made it more treacherous for people who were dependent on those resources. You know, the other part of it, of course, is the economic impacts that we've seen with the pandemic have led to more people who were just getting by now not having resources that they need. So not being people who were staying with friends, couch surfing, or were just one paycheck away from losing a place to stay, have now ended up being homeless. And that again has differentially affected First Nations people, and particularly people living away from home in urban areas. So those are all challenges that have faced us in the last few months and that we need to overcome going forward. So we're looking at how do we safely open up shelters? How do we find a concerted effort by a whole group of people to find supportive housing for people that includes the important mental health and substance use supports that people need more than ever right now. So those things that we're looking at, how do we get the recovery system going again? Because we shut a lot of things down where we told people to stay home in March. And if you don't have a home, or if you're in a recovery home that often has multiple people to a room, there are positive reasons for that, but it also makes it riskier when COVID is circulating in the community. So many of those places have had to decrease or close or reduce the number of people involved or that they're able to take in. So those are all things that we're looking at now across the province to see how we can build out these supports for people who need them now more than ever. I will say that, you know, we have had really good success working as a partnership with First Nations on protecting their nations from COVID, and that is reflected on the data that Dr. Mcdonald and I presented a week and a bit ago. And, you know, part of it is recognizing self-determination, that nations know what they need to do to protect their people. And how can we transfer that knowledge, that support that we give to nations to help them address this issue as well? And those are things that we've been talking about with the First Nations Health Authority and with our with people in communities across the province, recognizing that the need is greater than ever.
Go ahead, Richard.
Shannon, yes.
That is the end of our question period. Just for everyone on the line, if you have any further questions, they can be directed to media@fnha.ca. And I'll turn it back over to you, Richard.
Yes, I just want to thank our panelists for their really excellent comments and for presenting the data and an understanding of that data in a way that hopefully will help us go forward to focus on the issues that are so important. So I also want to make sure that we observe protocol, and I would ask Charlene to close us with a prayer. But I want to thank all for participating today. Charlene?
Thank you, Richard. Just before doing a closing prayer, I just wanted to maybe offer support to the Health Authority and the Ministry of Health through Dr. Mcdonald. you know, it's, I wish that there were opportunities for us to go another step and maybe we can do this together. But where we have high numbers of deaths away from our communities, that somehow we look at opportunities to have those people reconnect with our communities before we have a death. And again, I think that privacy and confidentiality are so critical, but also the rights to privacy. They should also have rights to be able to reconnect with family and community in case they can come home. So I want to look at other steps that maybe we can be helpful, because today's data is very disturbing and it's a responsibility that we have to work together. So just in closing, I'd like to just say a closing prayer, because I know that there's a community that's going through a service today for the loss of a loved one because of an opioid overdose. Great grandfather, creator of all good things, we pray to you and we thank you for this day. We thank you for the panelists, the discussions, their contributions, great grandfather. We pray to you to continue to guide the work that they do together. Help them to strengthen our need to be able to find the opportunities so that our people will have life. Great grandfather, we pray to you for those children that are left behind. Those families and those communities, great grandfather. We pray to you to give them strength as they go through their services. Great grandfather, we pray to you for our frontline workers, our doctors in the hospitals, our nurses that come into contact with our community members, to be able to be open, to provide the kind of service that they need to be well. Again, in closing, great grandfather, we pray to you for our leadership, our chiefs, to continue to be proactive so that we don't continue to lose our people to opioid overdoses. All my relations. Thank you.
Thank you, everyone. That concludes our event today. Reminder, for any additional questions can be directed to media@fnha.ca. Thank you to our panelists. Have a great afternoon.
Thanks. Take care, everybody.